Welcome back. Our last witness for this hearing is Dr. Helen Petousis-Harris. Dr. Petousis-Harris, please introduce yourself.
I'm an associate professor at the University of Auckland. I've got a PhD in vaccinology. I have been researching vaccines for about 27 years. The focus mainly is vaccine effectiveness and vaccine safety. And pertinent to this, from 2016 to 2020, I was a member of the WHO Global Advisory Committee on Vaccine Safety, and for the last 2 years of that, I was the chair of that committee, and I also led a subcommittee on vaccine safety crises communication.
Thank you, Dr. Petousis-Harris. It is the subject of trust, transparency and communication, lessons in vaccine communication from COVID, that I want to ask you questions about today. So we'll begin with some questions about all vaccines, and then we'll move to the question of communication. We have heard that vaccines are some of the most efficient tools in a pandemic. Why is a vaccine such an efficient public health tool?
Vaccines can serve a number of purposes, not just direct protection to the person who receives the vaccine. Vaccines prevent disease rather than treating it, so it's, I guess, before the ambulance at the bottom of the cliff. Most vaccines will protect not just the individual but the community by reducing or sometimes preventing the chain of onward transmission. And that's where what's called herd protection or community immunity can come into play when you get enough people vaccinated. It also saves money and time and resources. It's a very cost-effective intervention. You get fewer hospitalisations, and with that you can also prevent some indirect costs, such as people who miss out on healthcare because of the burden on the healthcare system.
We have heard how many people, were hesitant or against taking the COVID-19 vaccines. What are the risks of hesitancy or refusal in a pandemic?
I think during a pandemic, you see those things that I just mentioned, I guess, magnified. So you're seeing a lot more people at any one time experiencing severe illness, potentially deaths. You see again that influx, that burden on health systems, which is happening at pace, and it can be quite overwhelming. And you also lose the opportunity if you can't gain enough uptake of potentially that herd protection or that community immunity as well. And when that happens, we also see dramatic expansions in health inequalities, which you see in peacetime too a lot, but that really gets magnified during a pandemic. And I guess finally the potential for misinformation starts to gain ground, and from there we start to experience other problems as well.
Are these issues something new with COVID-19, or have they existed before?
No, vaccine hesitancy, if you like to call it, has been present since the first vaccine was developed for smallpox. So it's been with us, our ever-present friend that's come along, all vaccines. We understand it better now than we used to, but it's been described for perhaps 150, 200 years.
So prior to the COVID-19 pandemic, were there resources available with guidance about vaccine hesitancy and how to build trust in vaccination and how to communicate about vaccine safety?
There's been substantial resources available from, for example, the WHO really started to build up libraries on those sort of tools from about 2012. say, for example, in 2017, there was quite an extensive toolkit published and made available to member nations that provided guidance in a whole range of aspects on communication with respect, the area I'm familiar with, which is vaccines, with respect to vaccines, for example, toolkits for media, toolkits for government and health authorities, and so forth.
What were the guiding principles of that toolkit? What's the most important thing?
I guess there's some critical components that are. They're in the toolkit, but of course these things are based on what's now a fairly extensive body of evidence. First of all, one of those is to make trust a strategic goal. This is in terms of building resilience before you actually end up with a crisis. So you've got a lot of peacetime activities which need to be developed during peacetime. Communicating regularly, for example, not just in emergencies, keeping those communication channels open with your health sector and your public. Building vaccine literacy before it's needed. If people don't know anything about vaccines, then I think that leaves it open. Also, of course, fertile ground for misinformation. Making sure that your frontline people are well trained and confident in managing vaccine communications, because it's something that you need to be have a background in and understand, and also to prepare your systems to respond quickly. So that might be, for example, having the right networks already established so that you're not having to run around in a crisis. So I guess making sure that you have some resilience built into your systems before you have a pandemic, an epidemic, and what will probably come with it, a vaccine communication crisis, because it's usually inevitable.
So what was known prior to COVID about why people are or can be hesitant about taking a vaccine?
There's a number of really well established factors that I guess feed into what we might say vaccine hesitancy, which is a spectrum. It's not just a person might move within a spectrum from being very sort of confident and accepting into a place where they've lost their confidence and they don't want to be vaccinated, and anything in between. And the reasons for that can change, and a person can move across the spectrum. So it's not a fixed thing, but there's sort of like the 3 C's. One of them is confidence, and that's having trust in the product, the safety and the effectiveness of the vaccine, the healthcare systems, the policymakers. Also trust in the motivations of the people who are recommending the vaccine. So that's about having confidence. The complacency is if you don't see that the disease is a risk to you, then you're less likely to see a value in a vaccine. And then convenience, where they need to be easily accessible to people, and you've got practical barriers like navigating systems, for example. So those are generally the 3 factors that feed into what ultimately is vaccine confidence, trust, vaccine hesitancy.
You talked about a lack of confidence perhaps in the motivation of the people who are wanting you to take the vaccine. What about a lack of confidence in the safety of the vaccine itself?
We know from all of these perhaps now centuries of looking at vaccine confidence and hesitancy, the biggest component of that really boils down to concerns about the safety of the product, and a lot of that again comes into risk perception, where sometimes the perceived risk of the product is far greater than the real risk.
And is that related to whether the likelihood of catching the disease is seen as a low or a high risk?
Yes, it is, and I think and I'll give you some examples. If from a scientific perspective, we might see all these, a 1 in 100,000 chance of a serious side effect. The public perception might be, oh my God, I've seen all these reports of terrible things happening to people without, a context there. No vaccine is 100% effective, so there will be people who get vaccinated and get sick, so you'll hear reports about people still getting sick, so it might be perceived, well, it doesn't work. You might only have 3 in 1,000 vaccinated people hospitalised, and people will say, well, I don't know anybody that had it bad, because of course they're a victim of, if a vaccine works, it becomes a bit of a victim of its own success, and it seems hard to see the long-term benefit of that.
You've said a victim of its own success. Do you mean that really there's no visible effect when it works properly, so it's easy to forget or disregard the benefits? That's
right, because what we're trying to sell, if you like, is actually an absence of something. It's an absence of disease, and when I think it's very different when you're not seeing a massive wave of deaths and perhaps mass graves, for example, like some countries were experiencing. We didn't experience that. That wasn't so visible. And we didn't necessarily all know somebody who was severely adverse affected by the disease. So that really changes the risk perception. There was a lot of focus on the vaccine.
So what was known before the pandemic about the role of trust in vaccine hesitancy?
I think, again, it's well established that trust is a critical component in having in the resilience when something goes wrong, I think, and that is, and I can give you an example. For example, when we saw this play out just before the pandemic in Samoa, we're a fragile health system, but also had very low trust in the health system and also the government. And when there was a terrible error made and 2 infants died, there was a failure to communicate. People didn't know what had happened, and then the result of that was a plunge of what was already low trust into zero trust and very low coverage, and then of course ultimately a devastating epidemic and consequent deaths. So I think that's very well known, and there's a lot of examples of the role that plays.
And was the triggering event in that incident completely unrelated to the safety of the vaccine?
Correct. It was an error where a vaccine was, rather than being reconstituted with saline, it was an anaesthetic. Not something that can happen in New Zealand, by the way.
So what kind of events, and you've just given one example, what other kinds of events can intensify concerns about vaccines?
I guess a vaccine, it's often a vaccine safety, it's a vaccine safety communication crisis, but it can occur due to a number of potential events. And this is a real or perceived, so it doesn't necessarily be something real, but it can be perceived. It's equally as problematic. So, for example, you have an adverse event following immunisation. There might be a new study that's been published or data related to vaccine safety. Reports in the media and rumours, of course, and that's where you can get a lot of spread of perceived concerns, and also things like if a vaccine was recalled for some reason, that can also cause these communication crises.
What about a new safety signal?
Yeah, so I think that's absolutely critical because. And I think it's something that people don't appreciate, that once you license a product, it's based on tens of thousands of participants in, say, a randomised trial, you are not going to pick up something that's very, very rare. You just don't have the number of people. So there's a whole lot of systems in place to detect things that could be much rarer. You know, say, for example, a 1 in 50, 1 in 100,000, and then, 1 in a million, and so forth. And so when you get a publication that might say there's been some reported cases of something, it might be that that's a signal. It's not. It's something to investigate and follow up. It doesn't mean that that's actually causal. And we have a big challenge in actually communicating causality, and also the process. And people, one of the critical communication components is to explain this is what's happened, and this is what we're doing about it, and we'll keep you informed as we progress, which is vital to maintain trust.
So is a safety signal evidence that there may be an issue with a vaccine that needs investigation?
Yes, a signal is just that. It's a signal, and it's something that brings your attention. To bring your attention. Do we need to follow this up? Yes, this needs to be followed up, and this is how we're going to follow it up. And there'll be some stages involved in that, so that for example, the epidemiologists will kick in, and the studies will occur, and we'll understand it if there is a risk and communicate it.
And do I understand from what you've just said that things coming up as the doses that have been administered rise in number are to be expected? Absolutely,
and of course, what we want to see, ideally, in a well-functioning pharmacovigilance environment, is lots of reports, not because an event was necessarily caused by a vaccine, but when you're receiving lots of reports, it enables the detection of a potential signal, something unexpected, something weird. And those systems, by and large, work very, very well, and we had the whole world looking at the time. So these events that were rare and found, an increased risk was associated with the vaccine were picked up. They were investigated, and while some dropped by the way as actually not being causally associated, there were those that remained that we now have characterised and understand quite well.
Right. So given that it can be expected that new concerns, new signals will arise, some of which will be shown to be associated with the vaccine and some of which won't be, what guidance had the World Health Organization given about how authorities could build and maintain trust in vaccines?
I guess one of the first is that, and I mentioned building resilience, and that that happens before an epidemic, during your peacetime, during your routine program, and I think I mean, as I mentioned, those components. Also, aside from that, having being prepared for a crisis, and that is, you should already understand what your landscapes are. Who are your communities that you need to engage with, and whereabouts is hesitancy or concerns? Where are they likely to emerge? You should be doing routine surveys or social listening, if you like, these days, to constantly monitor what the sentiment is. What are people concerned about, for example? You need to make sure that your communication plans are adapted to the different, for example, your different communities, your cultures, and also media habits. And have, having thought through some scenarios is always, part of a preparedness plan. So you need to engage cross-sectorally. You can't just have something going on perhaps in the vaccine program. You need to have your civil society, your schools, religious groups. You need to have those groups identified before time, so that when you do have a crisis, you are ready to respond. And one of the, I think one of the nicest tools that has been available for some time is actually how to respond in a crisis, like we have observed. And it's a very simple 4-step process that outlines very clearly, the first step, gather you're in a circle. Second step, understand what the problem is. Third step's liaise with your stakeholders, because ideally you've already identified them and you've got relationships there already. And then then you make the decisions about communicating externally and in what ways and to whom and who's going to, be delivering those messages, etc.
Because we know that vaccine hesitancy is sometimes based on risk perception, did the World Health Organization recommend that there was communication with the population about the risks of the vaccines?
Yes, I think it's pretty well accepted that communicating risk is vital, and yet there is also, I think, a worry among some people that if you tell people about a risk, it will scare them and they'll run away. And actually, that's not the case. There's plenty of research to show that if you've got a risk associated with a vaccine and you inform the person about that as part of the informed consent, this is also essentially an established ethical obligation as well, that actually gains more trust. It doesn't lose trust and people don't run away. I think, but of course the providers do need to know how to have those conversations. But we've got examples. There's a lot of vaccines that have rare potential side effects. And when people are properly informed, it actually instills more trust than it loses. And of course, people feel very betrayed when they learn that there was some knowledge about a rare event and they were not informed because you've removed the agency.
You say you talk to people about the risks. Do you also talk to them about the benefits of the vaccine?
That's the other essential component. Of course, people need to understand what the vaccine's for, and the benefits that they themselves are likely to receive from the vaccine. But I think also, and I think we know from some research here too, is that people actually feel it's important to take a vaccine, even if they don't feel that they themselves are personally at particular risk, but if they also understand that they might be able to protect more vulnerable people around them. A lot of people will consider that in their risk and benefit assessment.
What about things like the intended benefit to the community in hospital beds being available, the health system not being overrun? Are they benefits to communicate?
Yeah, absolutely. And again, most people are actually community-minded, and again, the evidence shows when they're fully informed, and also as informed about uncertainty. Informing people about uncertainty is vital. You often don't have all the answers, and also what you need to communicate will change over time, and so you have to keep adapting your communications over time.
So you've said communicating about uncertainty. Is that uncertainty about the vaccination, about the vaccine, uncertainty about the pandemic? What sorts of things do you include under that category?
Well, for example, as the pandemic moved and we had this vaccine, and as time went on, the protection waned, for example, the effectiveness of the vaccine dropped. It all started to get a lot more complex to communicate. When we first had the vaccine, it was the clinical trials showed that it was 95% efficacious. Of course, that changed over time. But then you had the situation where you had people who, you were still preventing serious disease really, really well, but less so infection, and then the impact on transmission reduced, etc. And it all became many shades of grey, which poses a communications challenge, but it's an important one to I guess manage, because if you don't, you've left the door wide open for misinformation, and then we start to kind of, that trust, etc., starts to unravel.
Just thinking about the learnings and the science of risk communication, has the World Health Organization shared the lesson that risk communication is a core public health intervention?
Yes, and there's been lots of learnings, not just not those assimilated by the WHO, but lots of other efforts and research, and essentially. Risk communication is a core public health intervention, and it's not actually an optional nice to have. It's something that needs to be there all the time. I mentioned uncertainty. That must be communicated early and often. The social listening, making sure that the communication is two-way, is essential. And again, trust isn't just nurtured during the peacetime, but is not ignored in peacetime and suddenly built in a crisis, because that's not going to be so effective. Misinformation spreads fastest where there's a void, an information void. I think I've mentioned over-centralised messaging can backfire. And I think that's been established, and also...
I'll pause you at that concept, because is this risk communication something that anyone can do, or is it a specialty?
I think it's a specialty, and also it would need to be multidisciplinary to make sure that you've got the right experts on communications, but also that you've got the people who have the technical knowledge to make sure that what's being communicated is technically accurate. So yeah, it's a bit of a team effort.
And then do those people need to get all that information to the messengers?
That's right, and that's where you need to have those networks established, and so I appreciate there's resource involved in this, and I mean this would mean you've got people dedicated to actually working with those networks to get that message out there, and also not just with the people in the networks, for example, your church leaders or whatever, but you've also got the media you need to push out on different platforms as well, which again, that's another area of specialty and expertise.
If you're sending information out with the messengers to their communities, do you need to have someone waiting for the questions to come back?
You mean from the communities?
From the communities.
Yes, it's bi-directional, and if I can give an example of quite some years ago when New Zealand had a devastating epidemic, and at the time the largest mass immunisation campaign that we had ever had. At the time, we had a relatively low trust environment, and we also had extremely low vaccine coverage, particularly so in Māori and Pacific. Now, by working with, for example, the Pacific church leaders, the Pacific community actually achieved one of the highest vaccine uptakes, and I think, and that was maintained until recently. So for a period of about 15 years, it's been maintained. So I think it's a real, local example of how something can be done well and how effective it is.
Does this system that is recommended deal with rumours or potential misinformation?
And that's the other one big component is an area again that requires specialist expertise. It's a global problem. It's growing and needs dedicated and a consistent resource to both understand what is being said, but also, again, this is where your communications people come in to what's called pre-bunk, to try and build that community resilience against that misinformation. And I guess ultimately, in an ideal world, you'd be able to work with your policy and your regulators to try and regulate some of the platforms, like, for example, they're starting to do in Europe. So that's a big space too that needs maintaining during peacetime.
And do any of these large-scale communication plans undermine the importance of one-to-one communication between health professionals and patients?
No, often those are some of the most important conversations, and sometimes just 5 minutes can be incredibly valuable. But again, appreciate the resource. But also that is again where you need your frontline, your health professional to have been provided the resources that they need to have those conversations.
Thank you, Dr. Petousis-Harris. Can you please answer any questions? I'm sure there'll be some from the commissioners.
Commissioner Kavanagh.
Thank you. Thank you, Dr. Petousis-Harris. I have three perhaps quite blunt questions for you. The first is, did we experience a communication crisis with the rollout of the COVID vaccine? Yes. And was the health system listening? You talked about social listening. Was it listening?
I saw surveys early on in 2020, really before the vaccine. It seemed to slow down and that information seemed to dry up. So the listening, if it was happening, the information wasn't filtering out.
Okay. So did we leave the door open wide for misinformation?
Yes, we did.
Okay. So if we're thinking about the lessons that we have learned, would you say that those three things were very important? Is knowing the potential for the crisis, to be listening, social listening, and making sure that we don't leave the door wide open for misinformation?
Yes, and I think the year before, in 2019, we did this did happen with the epidemic, the measles, both the measles here and of course in Samoa, and there was no that this was a potential communication crisis, and there was no appetite to tackle that at that time. So again, these tools and guidelines have existed for some time. So I was disappointed.
Thank you. Thank you very much.
Professor, can I just take you right back to the beginning, and where you told us your qualifications included a PhD in vaccinology. What's the difference between vaccinology and epidemiology?
Vaccinology encompasses a whole lot of, it's quite multidisciplinary, so you're sort of understanding the infectious a little bit about the infectious diseases, a bit about immunology, and also a little bit of the social and vaccine program. So it's quite multidisciplinary. So including, of course, epidemiology. So it's a little bit of a jack of a number of trades.
Right. And does that involve you, with a novel virus, understanding how that virus works, how it infiltrates the immune system and so on?
In part, I would, this is where I turn to my virology people, etc. I think it enables me to understand the basics and to communicate those, but certainly, again, it's the domain of the virologist.
So, just for simpletons like me who don't have any expert knowledge of the areas in which you work, can you tell us, please, the difference between inoculation, vaccination, and genetic engineering?
Inoculation traditionally is referred to the process of, in this case it came about with back in smallpox times, where people before the development using cowpox would take the matter from a person who had smallpox. They'd take that and they would inoculate through the skin, through a cut or a graze, that matter, because they knew that if a person was infected via the skin, that they were less likely to die. And of course, smallpox had a rather large mortality rate. So that was seen as a preferable approach. And then when vaccination came along, that was related to vaccinia, the name of the cowpox, and hence the name vaccination. So the process of administering the vaccine is called vaccination.
So the cowpox was used as a proxy for the smallpox, and that provided antibodies, or caused the body to produce antibodies against the main disease that was being protected against.
Yes, it had been observed for a long time that milkmaids seemed to manage to avoid getting smallpox, and it was because they were actually being infected from the cows. Cows had a similar. It's a similar infection, but relatively benign in humans. And a milkmaid came to her boss with a lesion on her hand, and Blossom the cow had cowpox, and Edward Jenner saw an opportunity.
Right.
And there we have
So
it.
Then take us to genetic engineering. How does that relate to those two topics that you've just mentioned? So,
given the objective of a vaccine is to induce immunity, we require an antigen, and an antigen is just something that can generate antibodies. And we often do not need the entire organism, where we can actually now engineer the part that we want. So genetic engineering can actually, it gives you a purer product, you can target the bit that you want, and also for production that is also an advantage, because growing bugs is a bit of a pain if you can avoid that.
So is mRNA vaccination a form of genetic modification?
No, the product itself has been developed using genetic engineering, but the product itself consists of RNA. Now, RNA cannot modify your genome, because in order to do that, it would need some additional specific instructions, but it would also need to gain access. Once it's inside your cell, it would need to gain access into the nucleus where your genome is, and it can't do that. So no, it can't.
Why can't it infiltrate into the nucleus?
It needs extra bits and extra instructions, which it doesn't have. It's a one-way trip. You can get messenger RNA comes out of the nucleus, but it doesn't go back in, and it also disintegrates quite quickly. It's very fragile.
So the messenger RNA which produces proteins that in turn provoke antibodies. How long do they remain in the body?
The proteins? They initially, not long. I know that there's studies that have shown, picked up spike protein, some, days after, etc. But most of it is taken up into cells. So once it's taken up into cells, it's digested in those cells during the process and migration to the local lymph node where the immune response, the specific immune response occurs. So it's, I think probably days, but I know people have looked.
Right. So do those spike proteins, in your expert opinion, represent an ongoing health risk for people who get vaccinated?
There is no evidence of that. Essentially, for example, thinking about long COVID, if we see those syndromes of those debilitating syndromes, is less likely in people who've been vaccinated, for example. The research has identified no evidence for that, and of course continues. But so far, there's no evidence of long-term. And we've not seen that in the past with other vaccines either, when there are adverse events, apart from, I can give you an exception, but apart from, it tends to be within a window period afterwards for good reason, because there's a whole mechanisms involved, etc. So for example, if it was myocarditis, for example, you're going to see that within this window period, and when you see an increase in that window period, you know that a chunk of that is vaccine associated. So you've always got your myocarditis happening all the time, and then you've got you see a blip where you've got additional cases associated with the vaccine, and then it goes away, as with all the other adverse events that we have investigated.
So, is it fair to say that safety signals were picked up starting from around about mid-2021?
Earlier. And
was some of that from surveys done in Israel?
Yes, the initial signal for myocarditis came from Israel.
So we hear about myocarditis and pericarditis, that they are both heart ailments.
Yes.
And some people also suggest that anaphylaxis can be a side effect.
Yes, that's one that was identified within the first, and it was expected as well.
And that's basically an allergy reaction.
Yes, treated on the spot.
Which can be very serious if not treated.
Yes.
Now, you've said that a vaccine program can be the victim of its own success. Does that involve seeing what happened, say, in New Zealand compared with another country where vaccination wasn't successfully run as a campaign?
Yeah, I mean, there's been a lot of examples. I guess we've certainly got an example of everything from each country. Countries that were experiencing massive rates of infection and, of course, high mortality early on, and we know through history you get quite a high demand for a vaccine. I think when that's not the case, the demand is a little lower, I guess.
Okay.
Yes.
Now, you have talked about networks in the community, and you've talked about social listening. What kind of networks would you point to say these are the types of network that need to be engaged when we are trying to protect the country from an infectious disease?
You've got your central, health authority, and then they need to take responsibility for sort of orchestrating coordination. You've got your clinical, relevant clinical experts. So, for example, if we were talking about something that we wanted to give to pregnant women, you'd be including your midwives as a start, and your perhaps your paediatricians and obstetricians, etc. You've got to have your infectious diseases experts, sometimes vaccine experts useful, and also epidemiologists in that space are useful too, can help you understand the data. And your frontline, your primary care are essential people. Now, today, pharmacy would be another one to have engaged, and then the education sector. And then beyond that, you start, I guess, those examples, community groups, such as, of course, as I mentioned, the church faith leaders, people like that are really important. You've got your Māori leaders. Those are who you need in your.
If we look at New Zealand as a whole, there must be thousands and thousands of little networks spread throughout the country. And how important is it for government to engage with those networks in an emergency situation?
Yeah, vital.
Right.
And they need to all be given the information needs to go out very broadly.
And if that information is in technical terms, that's really got to be simplified and targeted towards individual communities.
Yes, and I think that's where it's important that, say, you take your community leaders and you give them the information as much background information as you can, and they need to be involved in shaping the messages to their community. They're the ones having the discussions. As long as they've got that background knowledge, they need to shape those messages, and that's where it's most successful.
How important is it for those local communities to hear from trusted voices within the community?
That's one of the most important. The trusted voices is, and then when I mentioned the 4 steps for crisis, for example, that is one of the most vital components in that process. And when I was leading the subcommittee, we did some case studies over a period of a couple of years, and we looked at both low, middle and income countries and examples of where things had gone rather badly for all sorts of different reasons. And we looked at what those countries had done at the time. And it was very clear every single time when those processes were not followed that you would not be able to mitigate your disaster. But if you'd had one and you did implement these processes, that you were able to actually regain the trust and get your program back online. So unfortunately, it was just before we actually presented the last findings at a meeting in December 2019. But those case studies and those learnings really showed that those 4 steps are vital and quite simple.
So do we have a combination of top-down and bottom-up responses that are necessary?
Yes, so you mean that listening again from absolutely, because the community can tell you what's required they know their community, they can tell you what's required, and we saw that, with the vaccine program, for example, rolling out where we had communities, community health leaders, for example, that said, look, this is what we need to do here in our community, and there was some delay over resourcing those communities to just get in there and get it done, because they're very good at it.
In the communication sphere, you've told us that technical correctness is important, but simplicity of messaging is also important. Is there a tension between those two ideas?
It is. It's hard. It's hard. And I think that's why you need to ensure that you do have a multidisciplinary team on it. Because I know in my experience, I used to work with immunisation information for both health professionals and for the public. And there'd be an iterative process where you're getting it like developing these messages, and you'd come by, say, the technical person, me, and I go, you just need to change one word, and then you're technically accurate, and it's simple, and it would be iterative, and it is a little harder, but it's also important.
Presumably, when you're trying to translate into other languages, that becomes a particular difficulty.
It must be really hard.
Professor, thank you so much for your contribution. It's
You're welcome.
Very, very helpful to the Commission, and we will consider what you've said very, very carefully indeed. Ms. Levy.
Thank you, Dr. Petousis-Harris. We will break for 2 minutes before the next witness who is waiting online.